All right, so this is a big topic. This is really just going to be an overview, addressing the treatments very briefly, as well as the journey of kind of how we got to this for complex lymphatic anomalies. So as you all know, CLAs are very complex and no disease is the same. These are chronic conditions. And so at this point in time, there's no curative treatments. But what we do need to say about treatments is that they typically are multimodal and they often require multiple specialists during different phases of care. These treatment approaches need to also be dynamic because CLAs progress and or they change over time. Now, historically, treatment was surgical and complication based, depending on when these complications developed. And our medical treatments or interventions were really limited. One analogy, I know this ages me with the Oregon Trail, but one analogy is this: on this journey, it was never about enjoyment. It was always about overcoming obstacles and challenges as they came. However, for CLA, there has been an exponential growth of our knowledge of pathophysiology, as well as genomic and drug discoveries in this last decade. So I made a timeline of just important points in our journey with CLAs and learning more about them. And really here in the initial part, just focusing on to the left side, which we can see there's a very broad range of dates here, but very little on the left side. But our story really starts with Dr. Jackson in 1872 with the first reported publication of Gorham-Stout, of an individual who had multiple abnormal fractures of his humerus and then never fully regained the humerus. And unfortunately, this patient, which he describes in detail, his arm just kind of dangled at his side for the remainder of his life. Fast forward to 1955, which was the landmark publication by Gorham and Stout of 24 cases of angiomatosis that caused massive bone osteolysis, which is where we got the name Gorham-Stout disease or vanishing bone disease. Only 6 years later, actually, in 1961, Ash and his group actually described additional cases of what they termed as heme lymph angiomatosis, which they actually pointed out that these looked to be different than Gorham-Stout in terms of the rate of effusions, the bone lesion distribution, soft tissue, and visceral involvement. And in fact, this is one of their patients to the right. You can see this purpuric lesion on the chest and on the back, as well as lung disease with thickening of the interstitium, and even an emphysema or obstructive pulmonary disease. So this is probably, obviously we're assuming, but a patient that has KLA. So unfortunately, with that improvement or these advancements in the 1950s, 60s, it went many years, partially because we had many years without further advancements, partially because of our technology, as well as we also did not have standardized terminology. So you can actually find many more cases of lymph angiomatosis in the literature, but they were called by many, many different names. This led to a lot of miscommunication amongst providers and particularly subspecialties. And it wasn't until 2014 that the ISFA classification system actually was revised and included Gorham-Stout and GLA as lymphatic malformations and KLA as an unclassified lymphatic anomaly. So like I said, historically, most of our treatments back in that time, those standpoints were surgical and interventional procedures for the different complications. One of the most common complications was effusions, so things like chest tube drainage, pleurodesis, pleurectomy, which is removal of part of the lung, thoracic duct ligation or reanastomosis. However, those are an embolization. However, those are arguably very difficult in very little ones. For progressive lesions, there is excision if possible, but many of the times, if it has to do with the ribs or the vertebra, that could actually cause more problems. Radiation, sclerotherapy, and amputation at last resort. For disappearing or weak bones, we have bone stabilization with rods, plates, screws. We have grafting, and again, amputation at worst case scenario. Very similar for progressive bone lesions and pain, and a a detrimental side complication, particularly for Gorham-Stout disease, is CSF leak, for which we can do blood patch, duroplasty, or last case again, scenario, a skull-based reconstruction. As I said, our medical care decades ago was restricted to supportive care, things like compression garments, lymphatic massage, pumps, anti-inflammatories, or for CLA, sometimes replacement of IVIG, albumin, and several others, many of which of these medications and supportive care we still use to this day. A quick note about radiation therapy. I think it sometimes gets lost. However, for localized bone lesions that are progressing quickly, this actually has reported success in up to 75% of controlling these very progressive bone lesions. However, the total dose of radiation is somewhere in the 35 to 45 gray. That's the most reported, which is very similar to certain brain tumors, and that causes surrounding tissue damage. And with that, we have early and late side effects: neurologic, neurocognitive, endocrine, neuropsychologic. And this is very concerning for our children and young adults who are still developing. Furthermore, with radiation, there is a risk for secondary cancer. So this is generally fallen out of favor, but is still used at times. So moving back to our timeline, you can see that from 2011, with Dr. Hamill's first reported benefit of oral sirolimus in 4 patients with diffuse microcystic lymphatic malformation, moving all the way up until just even this year reported use of alpelisib with CLA with PIK3CA mutations. These are just some of the groundbreaking discoveries in this area, many of which actually are from people in this room. So a lot has happened and a lot has moved in the last 10 to 12 years, which is exciting. And this is what has resulted from this is a treatment paradigm shift. Now we know about the importance of genotype and phenotype. We have been able to repurpose medications that were already developed mostly for cancer malignancy, and use these as targeted medical therapeutics for CLAs and other vascular anomalies. Our goals now are no longer just to manage complication, but to prevent disease progression and improve quality of life. We also have increased mindfulness to provide less invasive or less disrupting medications and treatment plans for the patient and the family. And like with the development of ISFA and groups like this, we have better collaboration, communication across subspecialties. So as I said earlier, treatment is generally multimodal with non-targeted medications, targeted medications, supportive care, surgical interventions, and ancillary staffing and support. So in terms of our non-targeted medications, the first is steroids. It's an anti-inflammatory, it does have immunosuppressive effect, but it is rapid acting, unlike some of our other medications. For CLA, it's most typically used in coagulopathy for KLA and effusions in KLA, GLA, and Gorham-Stout, often in a combination regimen, particularly when we're bridging or building up the other medications levels into the system. It can also be used for short bursts or short courses to help manage pain flares. It has been helpful for like bone flares, but short versus the long-term effects of steroids. Numerous short-term and long-term side effects, which many of us know about: increased appetite, mood, sleep disturbances, wound healing issues, weight gain, and the long-term effect that we get very concerned about is osteoporosis, compression fractures, pathologic fractures. The second non-targeted therapy is interferon alpha. This is used for effusions, progressive bone lesions. Really, there hasn't been studies of interferon alpha, but so case reports in small series have demonstrated it's most supportive for Gorham-Stout. Typically, it's used with other treatments such as bisphosphonates. Interferon alpha, however, has a lot of side effects, very common flu-like nausea, vomiting, body aches that can last for days. It's also, the pegylated form is also a weekly injection, typically given weekly. It also has cumulative or long-term effects such as hematologic abnormalities, fatigue, liver abnormalities, and depression, anxiety. I will say that most people, while they may tolerate a few doses, this is a medication that's very difficult to keep someone on long-term. Vincristine, this is typically used in our very sick patients with KLA who have coagulopathy, effusions, and organ failure. It is technically in the chemotherapeutic category. When someone is very ill and when we are using vincristine, it's generally administered weekly and then spaced out as tolerated. And it is recommended that it's given through a central line because extravasation of this medication, or if it leaks or pop an IV, if it gets into the tissue, it can actually cause tissue damage and death to the soft tissue. Side effects, the short term, it's bone, jaw pain, and constipation, but it's numerous with cumulative dose, hair loss, vocal cord paralysis, neuropathy, and what we call foot drop. And the last non-targeted therapy is bisphosphonates. The most commonly used here in the United States is Zometa or zoledronic acid, and this inhibits bone breakdown or resorption. We use these in CLA for lytic bone lesions and pathologic fractures, and evidence supports actually combined therapy for all of those CLAs that involve the bone. So Gorham-Stout, KLA, and GLA. Its side effects are usually pretty well tolerated, fever and some body ache short term, but we do have to limit the number of doses in a course because with cumulative doses, jaw osteonecrosis is a known side effect. So moving on to our targeted therapies, which here again, we see our PIK3CA and our RAF-MEK pathway involved in the different CLAs, and the crosstalk, there is quite a bit between them and a lot of interaction. And it is the overactivation of one of these pathways, depending on the CLA, that is associated with them. And these targeted therapies slow that or inhibit that overactivation. So sirolimus, you will see, or rapamycin or rapamune, you'll see at the bottom there that it is an mTOR inhibitor. And as mentioned earlier in this conference, it not only is downstream of the PIK3CA AKT pathway, but it also has inhibitory effect on the RAS MAPK overactivation due to that substantial crosstalk between both pathways and it being further downstream. It is actually used for quite a few indications in CLA: pain, effusions, the lytic bone lesions to try to prevent them from progressing. Some patients do have actual lymphatic malformations, engorgements, so it could decrease the bulkiness. In GLA, Gorham-Stout, and KLA, and there has been reports of some benefit with CCLA, but others there has not been benefit. Side effects are generally dose dependent, and it is pretty well tolerated, particularly on the lower doses, with mouth sores, headache being the most common, rash, GI upset. However, it is immunosuppressive, particularly at high doses. And when we first started for someone who has significant CLA, we do administer it at high doses to try to gain control of their disease. So while on high doses, you do need to be on PCP or PJP pneumonia prophylaxis. The second targeted medication or group of medications are MEK inhibitors, which includes trametinib, selumetinib, and cobimetinib. Trametinib, which is the most commonly used, however, there are increasing uses of the others, is given orally once daily. It's indicated for progressive lytic bone lesions and effusions in KLA and Gorham-Stout, coagulopathy in KLA, and as we heard in this program earlier, that it may be beneficial in some CCLAs as well. However, the toxicities of trametinib, and there are overlapping ones with selumetinib and cobimetinib, but at different rates. There are numerous: rash, diarrhea, fatigue, edema, hair changes, including loss. Most concerning are, it's uncommon, but I've seen it happen with severe rhabdomyolysis, life-threatening, decreased cardiac function, liver toxicity, eye issues, and blood abnormalities. And then the last targeted therapy, which is alpelisib, a PIK3, so it's upstream, it's at the beginning, and it is a PIK3CA inhibitor. Alpelisib is FDA approved already for the PIK3CA related overgrowth spectrum and is currently in clinical trial for that, but there's also an upcoming trial for lymphatic malformation with confirmed PIK3CA. Limited data, but currently in CLA, but as I said earlier, there was one publication just earlier this year that does show that it's supportive of use with CLA when there is a confirmed PIK3CA mutation. It's generally well tolerated. Again, mouth sores and diarrhea. There can be some hair changes, including thinning or loss and rash. The one side effect that we all monitor for closely is hyperglycemia, and there does seem to be a population of patients that are particularly at risk, probably those who are either pre-diabetic or have metabolic syndrome, that it may tip them into having diabetes. So it may not be for every person with a PIK3CA mutation. In conclusion, individualized treatment plans that are necessary for patients with CLA, and they need to be adaptive as these diseases change over time and progress. They should be multimodal, and they often need an interdisciplinary treatment approach as well. Because CLAs too, there's often overlapping phenotypes and complications, and it can be very difficult, especially as these change over time, to know which one, are you absolutely sure clinically, whether it's Gorham-Stout, GLA, or KLA. So this is where genetic testing becomes very important, particularly when we're considering using very targeted therapies like the PIK3CA inhibitor or a MEK inhibitor, due to you would not want, to use the incorrect pathway or inhibit the incorrect pathway. And lastly, our treatment options are expanding, as we know I'm here due to ongoing and valuable research by many people in this room. Thank you.